Yes, yes, okay, excellent. So what's remarkable, since the mid-70s, esophageal cancer has been the fastest growing cancer in Europe and America. If you look here, you see that esophageal cancer is way up here. Almost all other cancers are down or flat in incidence. This is quite shocking, and this began in the mid-70s. We're not going to go into what happened in the mid-70s that led us to where we are today. So the most recent data, and I believe this is an undercall, but we'll go with it, 18,000 new cases, 15,000 deaths, 5-year survival is dismal. Most patients present with advanced disease and they're dead within a year. The numbers, 4 cases per million in 1975, 27 cases per million in 2008. That's that huge increase that you saw in the previous graph. There's no end in sight. There are some experts that feel that within 10 years in the United States, esophageal cancer is going to exceed colon cancer as the second most common cancer killer in the United States. However, with early detection, you can turn it all around and people can actually survive this disease. So, one second. So what are the known risk factors? We've been talking about acid reflux disease all morning. I separated into 2 different symptom categories. One, something called heartburn reflux, which is the feeling of heartburn and regurgitation, and something we've been talking about, laryngopharyngeal reflux, what I call throat burn reflux. So the symptoms are a little different. Barrett esophagus is a risk factor, obesity is a risk factor. We touched upon diet earlier. So this is one of the most important take-home message, which is that throat burn reflux symptoms are alarm symptoms for esophageal adenocarcinoma. Throat burn reflux, this course is about hoarseness. We talk a little bit about cough, but hoarseness is what we all deal with. That's what the patients typically come in to see us about. So when someone is hoarse, we're thinking larynx, larynx, larynx. We should also drop it down a little bit and start thinking about the esophagus. Frequent throat clearing, lump-like sensation in the throat, sore throat, probably postnasal drip as well. These are the studies, I'll go into them in a moment. The mechanism, it's not only what comes up, it's not only reflux, it's what comes down to. This is just data in the last 10 years. Most of it comes from Nikki Johnston, who showed that you have pepsin receptors in the upper aerodigestive tract. You can think of them as dormant enzymes, and they awaken with acidic environments. So what's acidic? As it turns out, there are very, very few foods or things that we drink that are acidic. I call them the acid reflux dirty half dozen. Sugary soda, bottled iced tea, wine, we're talking about white especially, citrus, tomato, and vinegar. That's not a lot of substances. But these substances, no matter how many antacids you're taking, this goes back to what we were talking about earlier about the importance of diet. This is the importance of diet because you're going to activate these pepsin receptors and you're going to get inflammation. So, inflammation. This is a normal larynx and this is an acid-injured larynx. So the vocal folds, which should be thin, vibrating structures, you could think of a violin string. Here they look like kielbasa, right? They look like sausages. Look how thick this is. We call this the Puff Daddy larynx. It should be etched like Mount Rushmore. This is an inflamed, acid-injured larynx. You can imagine that this individual is going to be hoarse, at least.
Back up a little bit.
Okay, thank you. So acid reflux is a risk factor. We talked about the 3 risk factors. This is old data on heartburn reflux. The new data is very powerful. This comes from the GI literature. It's very, very well powered. And it showed that laryngopharyngeal symptoms, hoarseness again, and cough, better predict the presence of esophageal adenocarcinoma than typical GERD symptoms. A few years later, some of the same group, some other investigators showed that medically treated patients with mild or absent GERD symptoms and medically untreated patients with severe atypical symptoms, that's the cough that Dr. Allman was talking about, that's some of the quote-unquote unresponsive to PPI patients, have significantly higher odds of developing adenocarcinoma compared with the medically treated patients. And there's like, what is this? Why is this happening? So they feel that this may explain the failure of our current diagnostic paradigm, where the threshold for a primary endoscopic procedure is heartburn. It's all about heartburn, but really, it's about throat burn. Okay, Barrett esophagus. What is Barrett? Barrett is when you have stomach lining creeping up into the esophagus. It's specialized intestinal epithelium. To make the diagnosis, you need to have gland-forming epithelium with goblet cells. What is the risk? You have a 40 times greater risk of developing esophageal adenocarcinoma. There have been some recent studies that say it really isn't 40 times, it may be 32 times. Whatever it is, it's a huge difference compared to someone who doesn't have Barrett, and that's really what we're looking for as we're doing our diagnoses based on just throat symptoms. So here's an example, hiatal hernia. You can see rugal folds above the diaphragmatic pinch, and over here you see this area of salmon-colored tissue above the Z-line. This is a short segment of Barrett. Obesity is a risk factor. We talked about body mass index earlier. There are studies that show that increased BMI leads to increased gastroesophageal reflux symptoms and exposure of the esophagus to carcinogens. What are the options for examining the esophagus? You can sedate and look, or you could do it unsedated, something that we're all familiar with. It's called transnasal esophagoscopy. You don't have to sedate. The gag reflex is in the mouth. When you go through the nose, you go behind the gag reflex. So we're using body physiology, body anatomy to make this happen. There are different ways to do the exam. It doesn't matter how you like to do it. You can use fiber scopes, you can use distal chip scopes, you can use D-shaped scopes with sheaths. It doesn't matter. The point is there are many ways to do this through the nose. The thing that's the common denominator, you're not using conscious sedation. So here you're seeing a T&E, and there's just a couple of things I want to point out here. We numb up and decongest the nose. I do not anesthetize the pharynx or hypopharynx at all. I actually have the patient sip water through the exam. Every time the patient swallows, you initiate a secondary peristalsis and the esophagus opens up. What you're seeing here at about 7 o'clock is an inlet patch, which is just ectopic gastric epithelium, nothing really to worry about. But as we're going towards the gastroesophageal junction, what you're going to see at 7 o'clock is, again, a tongue of salmon-colored epithelium. You're going to see it right here. There it is. That's Barrett esophagus. Okay, we can stop the vid. So the reason T&E is much safer is you don't have intravenous sedation. So what's the issue? This is well established, again, in the GI literature. Almost all complications related to upper endoscopy are because of intravenous sedation. They call it cardiopulmonary unplanned event. What does that mean? That's a medical speak for heart attack, stroke, or respiratory arrest. We're not talking about death, we're talking about morbidity. And there's a defined risk. It's 0.5% a year. We do 10 million upper endoscopies a year in the United States. That's 50,000 patients a year. That's a lot of patients. That's a lot of morbidity. When you're doing an unsedated exam, you can go back to work the same day. If you're using an endo sheath in those situations, there's no risk of cross-contamination. Also much less costly. Without conscious sedation, you don't have the facility fees. Facility fees are used for the extra monitoring that sedation should require. And again, it's very costly. On the higher end, it's about $3,000 every time someone is sedated. Again, at 10 million procedures, you're talking about $30 billion a year. Likely half of those procedures could be done in the doctor's office, saving about $15 billion a year. Even though the healthcare budgets are huge, that's still a huge recurring number. So what can we do? Start with the conversation with the patient. Dr. Fried just talked about how important it is to discuss things with the patients. Same thing. Let them know. Let the patients know that there are alternatives. Let patients know that when they have throat symptoms, hoarseness being the focus here, chronic cough also, these are alarm symptoms. The esophagus needs to be examined. Frankly, I don't care how you examine the esophagus. Just suggest to the patient, get the esophagus examined. And finally, allow patients to know that there are options when it comes to sedation or no sedation, and that transnasal esophagoscopy is an option.